Assalamu alaikum. This lecture is about acute infectious upper airway obstruction. The objectives are to know the etiology, natural history, management, and parental advice about how to care for a child with acute infectious upper airway obstruction. Mainly the most common laryngotracheobronchitis and the most serious epiglottitis. The narrowest portion of the upper airway is located in the subglottic region, where the cricoid cartilage encircles the airways just below the vocal cord. The term croup means a group of acute and infectious processes characterized by barking cough. May be associated with hoarseness of voice, inspiratory stridor, or respiratory distress. Stridor is a sound. It's a sign. It's a harsh, high-pitched respiratory sound, which is usually inspiratory, can be biphasic, and produced by turbulent airflow. It's a sign of upper airway obstruction. It's not a diagnosis. Now, laryngotracheobronchitis is the most common cause of infectious upper airway obstruction. And it's the most common cause of the condition which is called croup. For this reason, laryngotracheobronchitis is called the croup. It's mainly in the glottis and the subglottic area and may extend down to the bronchial tree. Parainfluenza viruses with type 1 is the most common, account for about 75% of cases. Other viruses, influenza A and B, adenovirus, RSV virus, measles, other viruses, and mycoplasma pneumoniae have been also implicated. Laryngotracheobronchitis occur in children around the age of 2 years. The peak age is 2 years. There is higher incidence in males than females. It occurs during late fall and winter, and there is a tendency for recurrence, with some cases report family history of similar condition. The condition usually starts with upper respiratory tract infection with rhinorrhea, pharyngitis, cough and low-grade fever for 1 to 3 days. Then the characteristic barking cough, hoarseness of voice, and inspiratory stridor. Dyspnea, if occurs, it's usually mild in severity. For the physical signs, usually we see signs of upper respiratory tract infection and inflamed pharynx with slight tachypnea. Rarely suprasternal intercostal restrictions and biphasic stridor are seen. If we see hypoxia, cyanosis, pallor, or obtundation, they need immediate airway management. Regarding the investigations, the diagnosis of laryngotracheobronchitis is usually clinical, since the clinical features are so characteristic, and if neck X-ray is done, it might show the typical subglottic narrowing or steeple sign on the PA view, as seen in the next slide. Here, this neck X-ray shows clearly the narrowing of the upper trachea in the area of the subglottic region, forming what is called the steeple sign. The differential diagnosis of a group as laryngotracheal bronchitis are some infectious causes of upper airway obstruction and other non-infectious causes. The infectious causes like bacterial tracheitis, retropharyngeal and peritonsillar abscess, and diphtheria. The other causes might mimic foreign body, angioedema, laryngeal web, vascular ring, laryngeal papilloma, and subglottic hemangioma. The mainstay of treatment for children with a croup is airway management. Most acute croup can be managed safely at home. Mist has been traditionally used to treat a croup at home. Nebulized racemic epinephrine is an accepted treatment for moderate or severe croup. The effectiveness of oral corticosteroid in viral croup is well established. One of the conditions that might mimic laryngotracheal bronchitis is what's called spasmodic croup. It's a transient, mild condition affecting young children characterized by a state of a croup. Usually the child is aroused at night with croupy cough and stridor, and it might be relieved easily even on the way to the hospital once the temperature of the environment is changed. It's usually not associated with a prodrome of viral infection, neither with fever or toxic symptoms, and the cause might be due to allergic origin. Bacterial tracheitis is of bacterial origin, usually Staphylococcus aureus, complicating viral infection affecting the trachea, is of rapid onset of cough and biphasic stridor and toxic appearance, and sometimes hoarseness of voice. This condition is a serious condition affecting children of the same age group of laryngotracheal bronchitis, and many times it might need endotracheal intubation and tracheal lavage. Acute epiglottitis or supraglottitis is the most serious and dramatic, potentially lethal condition caused by Haemophilus influenzae type B bacteria, and after introduction of the HIV vaccine, other bacteria appear to cause this serious condition. The clinical features of epiglottitis in a healthy child suddenly develops a sore throat and fever. Within hours appears toxic with difficulty swallowing and labored breathing, drooling and hyperextended neck in an attempt to maintain the airways, with the characteristic 4Ds of dyspnea, dysphagia, drooling, and dysphonia. The diagnosis of epiglottitis should be done in a well-equipped ICU. When the diagnosis is certain or probable, laryngoscopy should be performed quickly in a controlled environment. Visualization of a large cherry-red swollen epiglottis by laryngoscopy and the classic radiograph of a child who has epiglottitis shows thumb sign, which is seen in the next slide. This is the lateral neck X-ray, which shows clearly an enlarged epiglottis obstructing the upper airways. Acute epiglottitis should be considered as a medical emergency and needs immediate treatment with an artificial airway placed under controlled conditions, either in an operating room or in the intensive care unit. Antibiotics should be given, like ceftriaxone or cefotaxime, for 7 to 10 days. Complications of infectious upper respiratory tract obstruction depend on the causative agent. If it is in the form of laryngotracheobronchitis that's caused by virus mainly, bacterial complications of viral infection might occur in the form of pneumonia, cervical lymphadenitis, otitis media can occur in the course of laryngotracheobronchitis in about 15% of patients. Meningitis, septic arthritis might occur in the course of epiglottitis. Mediastinal emphysema and pneumothorax if tracheostomy was done. Toxic shock syndrome is associated with Staphylococcus aureus infection and might complicate bacterial tracheitis. Now, untreated epiglottitis has a mortality rate of about 6%. If appropriate treatment is initiated before the patient is moribund, the prognosis is excellent. The outcome of laryngotracheobronchitis and spasmodic croup is also excellent. Thank you and good luck.